Good evening to all. Welcome to Ask Your Mentor program, season 4. This is a program initiative of AOMSI Tamil Nadu and Puducherry branch. This program has been successfully conducted for the past 3 years with aim of helping the exam going PG student to face the university exams, theory as well as practicals. Renowned teachers from all over the country take part to clarify the doubts of students. So this is the 4th year of this program. Now I invite the President of Tamil Nadu and Puducherry branch, Dr. Subramanian, to say few words and inaugurate the session.
Thank you, Dr. Sasikala.
Yes,
Am I audible? Yeah. Thank you,
yes,
Dr.
audible.
Sasikala. Thank you, Dr. Sasikala. Thank you, Dr. Arun, for arranging an excellent session. And we have got 12 sets of program for 12 days, and it is a 360-degree coverage of the entire syllabus of oral and maxillofacial surgery for the postgraduate students. Please be attentive and please attend regularly, and don't miss out any class in this web series, because all the stalwarts in every subject is being called for to do the subjects for you. So it's a good opportunity for the students to have a revision of the entire syllabus in 12 sets of program. I thank Dr. Ilavenil, Dr. Vandana, Dr. Sasikala, Dr. Kalpa Pandya, and Dr. Arun Vignesh for their fantastic efforts in organizing this event. I thank all the participants as well as the mentors who is today going to conduct the program. Thank you all and welcome you all for this excellent series, season 4 of Tamil Nadu Puducherry chapter AMSI Ask Your Mentor series. Thank you. Thank you.
Thank you, sir. Now I request the Honorary State Secretary, Dr. Arun Kumar, to say few words.
Thank you, Dr. Sasikala. And this was a unique program wherein the examiner will be examined. The examiner will be in the hot seat.
Arun, you are muted. Just hold on a second.
Yes. Sorry, I think Dr. Girish Rao is just joining. He's just calling me. Our General Secretary was supposed to join. He has got some technical. Issues. Sorry for the interruption. Our secretary just called me. He's having trouble joining in. He will join in due course. Meanwhile, this is a program started by it again by our former secretary, Dr. Jinson, and team. And this team, Ilavenil, Sasikala, Vandana, Kalpa, and Arun, have been doing a wonderful job for the past 3 years. And it has been a very highly successful event. So we didn't want, we just want to continue and update this this year as well. So thank you for all the coordinators, moderators, and the panelists for joining us. This is going to be for a month-long program. It's not easy to conduct such a program for such a long period and a sustained period. Kudos to the team. Welcome you all again. I just wait for Dr. Girish Rao to join in a few minutes. He has been a constant support for this, for all the endeavors of AOMSI Tamil Nadu and Puducherry chapter. He was very much appreciative of our state chapter. He will join us in due course, just time. Thank you, Susik.
Yes, sir. Thank you, sir. Now I request Dr. Jimson, sir, representative of Asian AOMSI, to say a few words.
Thank you, Dr. Sasikala. Thank you, Dr. Subramaniam, President, AMSA Tamil Nadu Puducherry Branch, and Dr. Arun, Honorary State Secretary, Tamil Nadu Puducherry Branch, for continuing this fantastic program that we started 3 years back. And the postgraduate trainees from all over India, and in fact, participants from different parts of the globe has also joined this unique program. And I should compliment the team behind the success of this. Actually, Dr. Ilavenil, Dr. Sasikala, Dr. Kalpa, Dr. Arun, Vignesh, and Dr. Vandana for doing this fantastic, taking forward this fantastic initiative. Like what Dr. Arun said, it is not easy. And every other day there is a program, and every other day there's a new topic in place. So to get these speakers and get the confirmation from the speakers, prepare these slides, and to have a trial session and then go on live, mean task. So best wishes to all the postgraduate trainees, makers of this opportunity, spread the word, and best wishes for your exams as well. Good luck.
Thank you, sir. Now
Thank you.
we move on to the
Sasikala,
program.
I think
Yes.
Dr. Girish Rao sir has joined.
Okay, sir.
Please welcome. Sir,
Now
are you in?
Yeah. Can you hear me at all?
Yes, sir.
Yes.
I just
Fantastic.
yes, sir. Welcome to the show, sir. Welcome to the show, sir. It's been a huge encouraging part. I just texted him yesterday, almost in the afternoon. Sir immediately agreed to come for this inauguration. That is very glad for us. And thank you so much, sir, for giving us so much of support and encouragement, sir. Please have a few words about this, sir. Thank you, sir.
Sure. Well, good evening, everyone. And it's such a pleasure to be here today with the Tamil Nadu and Puducherry chapter of AMSI. This is one of the best chapters which has been leading a lot of educational programs across every aspect of maxillofacial surgery. Must congratulate the President, Dr. Subramaniam, Secretary, Dr. Arun, Dr. Jimson, and every member who is there in this Tamil Nadu chapter, who is putting in so much of effort to make such a huge difference. This program is very exciting. Ask the Mentor. We just concluded recently the the postgraduate mastership program which we had. It was very well attended by more than 1,200 postgraduates across the country. And then we had the face-to-face TIVA program, which was very well organized by our Vice President, my dear friend who did this entire program, which was helped by a number of extremely senior maxillofacial surgeons. When Dr. Manikandan came up with this idea, I said, you take the lead and do this program. And that was extremely successful. We had some fantastic feedbacks also from that. It was for the very first time, standardized presentations which were done. It was created by one member and then basically mentored by a very senior maxillofacial surgeon and presented by young crop of very senior maxillofacial surgeons. And thereby we have actually involved more than 120 maxillofacial surgeons to do that program. And this is something which I believe is going to make a big difference for our postgraduates and exam going students who can actually get their doubts clarified on a one-on-one basis. So if there are any doubts, I would definitely request all the postgraduates to actively be a part of this entire session, which is done for them. And every aspect of maxillofacial surgery is being covered in the multiple sessions. I went through the whole program. It looks very exciting. And sometimes I think I wish I was a student at this point of my career. So it's so exciting to get so much of knowledge sharing between the senior faculty and our residents. I'm wishing everybody the very best. And again, I'm congratulating the Tamil Nadu chapter and the Puducherry chapter, which is doing some phenomenal work. Keep the good work which you're doing. Come up with some creative ideas like this and make maxillofacial surgery a household name, make it popular, make it very, very, very successful for the younger generations to have great careers. Thank you so much.
Thank you,
sir,
sir.
for your wonderful words. Thank you again for coming us to the show in spite of your busy schedule and taking time off during your clinic time. Thank you so much, sir. It means a lot to us. Thank you so much, sir.
And now we move on to the program. Today's topic are local anesthesia, general anesthesia, and sedation. Mentors for these sessions are Dr. Lakshmi Shetty for local anesthesia and Dr. Balaji for general anesthesia and sedation. The moderator for the topic local anesthesia is Dr. Kathiravan. Dr. Kathiravan Selvarosu is working as an associate professor and PG guide at Savitha Dental College and Hospital and director of Kathiravan's Dental Care. He completed his graduation in 2009 and PG in 2014 from SDM College of Dental Sciences and Hospital, Dharwad. He is a gold medalist and best outgoing, and he has received best outgoing postgraduate award. He has received fellowship of Indian Board of Oral Maxillofacial Surgery in 2019 and fellowship in International Congress of Oral Implantologists in 2021, currently pursuing PhD research at Savitha University. He has 40 plus publications in national and international journals. His areas of interest include orthodontic surgery, oral onco surgery, and reconstructive microsurgery. May I now request Dr. Kathiravan to introduce the mentor and start the program.
Warm welcome to all the dignitaries. Thank you for the kind words, ma'am. And facing a small. Okay, so heartiest welcome to our speaker, Dr. Lakshmi Shetty. Ma'am has qualified MDS and she's a fellow in the Indian Board of Oral Maxillofacial Surgery. She's a fellow in the International Board of OMFS, and she has completed AOCMF fellowship in cleft and craniofacial surgery. And she's currently associated as a professor in D.Y. Patil Dental College and Hospital, Pune. And she is a professor currently, and she has 13 years of surgical experience. To her laurels, ma'am has won more than 26 awards, of which the namely they are the late Rahul Shakar Pure Award, and then she has won the Fellow of International Board of Certification Specialists Maxillofacial Surgeons Award, and in 2020 she won the Best Delegate Paper Award in the AOMSI conference, and in 2021 she won the Dr. P.D. Patel Young Researcher Award, and again in 2021 she won a first prize in podcast competition, and she came as a runner-up in Innovative Ideas contest in 2021, and the best of all is the 2021 Dr. Emerson Jinwala Trophy. She won the Best Delegate Paper Award in the 45th AOMSI, and very proud to tell that even I was there in the same conference, and I listened to the ma'am's lecture, which was one of the wonderful lectures I've listened to. And she completed an AOCMF fellowship in cleft and craniofacial surgery in 2021, and again in 2022 she won the Best Delegate Paper Award, and in 2022 she got the Fellow of International Medical Sciences Academy. And apart from that, she has got a Staff Appreciation Award in 2021, 2022, and 2019. To her accolade, she has given more than 30 lectures, and she has performed. She has more than 56 publications in national and international journals. So we welcome you, ma'am, to this great show. Without further ado, we would like to move on to the presentation.
Thank you. Thank you, Dr. Kathiravan, sir. I thank AMSI Tamil Nadu and Puducherry branch for this opportunity. So to start off with today's session on local anesthesia, I think the first question that was asked was about preemptive analgesia. This is something which is a topic which is associated, like I think most of us tend to associate this with pain and non-steroidal anti-inflammatory drugs. But yes, it also has a relevance in terms of local anesthesia. When someone asks you about what is preemptive analgesia, This particular term was proposed by Kreil, and it is something to do with the altering the process of the input of pain. So basically, whenever we are treating a patient, and especially when the whole foundation of maxillofacial surgery rests on treating the post-operative pain, preemptive analgesia has its role in altering this sensory input, especially in central sensitization. So what do we mean by this? Basically, initially it was towards the initial pain that people used to give analgesics or probably maintain the field of analgesia during the surgery, intraoperatively, or start before the surgery. So all these three concepts were fused, and presently the evidence-based studies relate, especially in the article that has been mentioned in the Journal of Anesthesiology in the year 2000. Very clearly, they have mentioned that the pain hypersensitivity can be controlled at various different phases. It could be at the initiation phase, or it could be at the reinitiation phase, or in the maintenance phase. Any of these times when we give or inject a nerve block, that is through the medium of local anesthesia or through peripheral nerve blocks, we are trying to stop the sensory input impulses, and in turn helping effectively in the maintenance phase of controlling pain. So whenever we are asked a question on preemptive analgesia, you basically have to say that the efferent inputs which are causing pain are inhibited with the help of many agents actually, and local anesthesia along with agents which are there in general anesthesia, non-steroidal anti-inflammatory drugs, systemic intravenous, non-steroidal anti-inflammatory drugs, ketamine, all of these drugs all together, even opioids, have a role in preemptive analgesia. So that is the answer that is required when you're questioned about this topic. So the second question that was given to me was about ophthalmic complications following the local anesthesia administration, mechanism as well as prevention. This is one of the favorite query always. I think most of the patients come up with this query that if I have an upper maxillary tooth extraction, will I land up in blindness? This is, I think at the outpatient department, most of us would have encountered this particular question. The answer to this that you need to give is yes, there is a lot of case reports, case series. There's even a very interesting article in the Swiss Dental Journal on the ophthalmic complications following the administration. But out of all these many articles that we've gone through the scientific literature, the most common that we see, or you can enlist as ophthalmic complications, our patient is complaining of an accommodation disturbance. Patient is complaining of loss of sight, which is also called as scientifically as amaurosis. Double vision, which is the most common complication, which is otherwise known as diplopia. Anophthalmos, or the recession of the eyeball. Miosis, which is nothing but the contraction of the pupil. Mydriasis, that is the dilatation of the pupil. Paralysis of the various muscles which are responsible for the eye movements, which is also called as ophthalmoplegia. Or drooping of the upper eyelid, commonly known as ptosis. But along with this, if there have also been reported case reports, especially in the scientific literature, which talks about Horner's syndrome, having symptoms or signs of ptosis, meiosis, and paralysis of muscles, but that is only when the injection has reached till the stellate ganglion. So how does this happen? There's a very interesting article on ocular complications associated with local anesthesia. It's a review article in the Dental Clinics of North America 2010. Now, what do they suggest, or what do they say as the pathophysiology is that whenever we inject, especially the inferior alveolar nerve block, right, which is most common block which is used in the mandibular region, if a patient complains of diplopia, the reason for this is the intravascular injection of the local anesthesia touching the inferior alveolar artery, which lies very close proximity and which may have a correlation with the middle meningeal artery as well as the maxillary artery. So some amount of the pressure of the intravascular injection may be a cause. You can see in the diagram very clearly that there is a relation with the maxillary artery along whenever you're injecting in that area. So what happens is that the ophthalmic branch of the middle meningeal artery generally has an anastomosis with the lacrimal artery. And there where the question comes, where the effect to the muscular region of this area, that is the lateral rectus muscle, gets affected and causes the paralysis of that muscle. And that is the main reason for the diplopia in the patient. This is the arterial route. There could be a venous. Whenever there is a question, the reasons could be the arterial congestion or the venous. So when it is related to the venous congestion, that is the venous system getting activated. That is again to the if at all you have had a maxillary injection in the sense of the posterior superior alveolar nerve area, and then entering into the pterygoid plexus of veins. And this again maybe from here the pressure symptoms are transferred towards the abducent nerve, further towards the cavernous sinus, and this may lead to the paralysis of lateral rectus, again leading to diplopia. So whenever we're calling paralysis of the eye, this basically happens due to the paralysis of the oculomotor nerve. And chances of blindness, although have been reported by author Kaiser and Rishi Raj, that there have been reported blindness in patients after a maxillary nerve block. Now, the reason being here, the central retinal artery, which is present, which is a small branch of the ophthalmic artery, any anesthetic solution which is entering into the middle meningeal artery may enter into the ophthalmic artery, and following that, it may cause blindness or loss of the pupillary light reflex. Patients complaining of ptosis, strabismus, and loss of accommodation is all related to the ciliary muscles getting affected with the same pathway that I mentioned due to the injected solution entering into the parasympathetic supply and affecting the short ciliary nerves. Now, they can affect the oculomotor nerve and causing all the changes possible. As already mentioned, the accidental injection of the local anesthetic solution into the stellate ganglion is the cause for Horner syndrome. So there are cumulative, I think this pathophysiology, especially this diagram, easily tells us as to how these interdigitation of the arteries, the veins, and finally the pterygoid plexus, as well as the maxillary artery and the middle meningeal artery, as up till the lacrimal artery, are responsible for the various ophthalmic considerations which are happening due to a local anesthetic solution. So prevention, of course, the most important thing is not to panic. As a maxillofacial surgeon, of course, you need to have your stability in mind. Reassure the patient regarding the usual complications which can happen. Continue to monitor this patient. This has been proposed by Lee and Vigil in their guidelines, where they've mentioned that if suppose you find that the muscular weakness has occurred and there is some amount of eye movement restriction, or there is any cause for damage to the eyeball, then the gauze dressing should be placed. Functional monoocular vision, if at all, if it's affected, then make sure that the patient, reassure the patient and make sure the patient is taken care. And if it is not under your jurisdiction, please consult an ophthalmologist for immediate attention to the complication that has occurred. So regular follow-up of these patients are very, very important. So
that's a great topic you have explained, ma'am.
Thank you,
many
sir.
times we have asked this the questions from our students. How could LA from the oral cavity reach the eyes? So that was a great explanation.
Thank you, sir. And I think most of our patients also tend to ask this one question, that
definitely they ask this question
from various backgrounds. It could be urban, semi-urban population. I think they give us the same question, like, will it affect my eye? But actually literature has the justification, sir.
Okay, great.
Yeah.
Moving on to the next question, ma'am.
Yes.
The next question is reversal of LA. How do we do that and how do we achieve that? Please explain on that.
Sure. So I would like to tell every student or whoever is watching this thing, I think reversal of local anesthesia, the very textbook that you need to refer regarding this particular answer is the textbook written by Roberts, which is headed by the name Local Analgesia in Dentistry. Why do you need to reverse LA? Now, most of the time, I think we ask this very favorite Viva question. I think at least I remember my guide asking me this. There is a musician who wants to perform, who has to undergo an extraction. But then after the extraction, he needs to go and perform his whatever, music that he plays. So what would you do? How would you reverse the LA? So this is the pattern of question that is generally asked. Or maybe why do children have to be advised to have a short LA or a reversal of LA? Especially children are more prone to bite the lip, or in a medically compromised patient or a geriatric patient, there's a need for reversal of LA. And how does this happen? It is happening with the help of the drug called phentolamine mesylate. And this particular drug, especially this has what is known as, it is known as an alpha adrenergic agonist. So basically it counteracts, very important thing that we all know, local anesthesia is having a vasoconstrictor called adrenaline. Now this has the property of counteracting the vasoconstrictor effect. So it helps in vasodilation and in turn causing the effect of the LA to wear out. So this particular phentolamine mesylate, which otherwise commercially they are available as Oravers, the drug dosage is that half cartridge of this 0.2 milligram of the drug. When it is given with the half cartridge of local anesthetic, it has to be administered about 0.2 milligrams. And one cartridge of the drug, it is again with one cartridge of the local anesthetic solution has to be administered. So there are various combinations again. Now, trans-electric nerve stimulation also helps in tissue perfusion, and indirectly it also helps in the effect of the reversal of LA. So basically, the two things that we expect from any student who's answering this question is which is the drug. And this has been actually studied extensively by Dr. S.R. Watt-Smith, who was the first one to coin this proposal of using this drug for reversal of LA. So are you able to see the question, sir?
Ma'am, I just have a doubt regarding this.
Yes, sir.
How well does it work when we give a block to the patients? Does it work only on infiltration, or is it effective even when we give a block?
So this is basically we are giving in a combination with the local anesthetic. I mean the various the area we are going to give is through the block itself, no, sir? In that area itself.
Okay. So moving on to the next question, ma'am. What is rule of 10 and what is rule of 25 in LA, in local anesthesia?
Yeah, so I think we have heard many of rules of 10 and the rule of 20. So what is this rule of 10 and rule of 25 in local anesthesia? Per se, this question needs to be addressed mostly in the pediatric group of patients. There's a beautiful article in the Journal of Anesthesia and Pain Control written by Saragi et al., which describes about both the rules, the rule of 10 as well as rule of 25. Both are related to the pediatric group of patients. Now, what is rule of 10? Rule of 10 is basically, now I'm talking about rule of 10 in local anesthesia. Rule of 10 is related to the tooth number plus the age of that child. If it is less than 10, then the administration of the local anesthesia should be through the infiltration route. If at all it is greater than 10, then a block technique can be used. So this is related to the techniques of local anesthesia in terms of the tooth number and the age. Rule of 25 is related to the number of cartridges you can give in terms of the LB, that is 25 LB weight of the patient. Then one cartridge could be used, and you need to double it if it is patient is weighing anything between 50 LB or LB weight. So it is related to the weight and the amount of cartridge of local anesthesia that can be used. So all of these two rules are related to avoiding any kind of complications in especially pediatric patients. So this is related to the administration of local anesthesia.
Thank you.
Sir.
Moving on to the next question, ma'am. Is there an antidote for local anesthesia?
Yes, of course, there is an antidote for local anesthesia. The antidote that has been reported in most of the literature is about lipid emulsion, which can be used as an antidote. Now, how does this work? It basically works that it absorbs the offending lipophilic toxins and it is able to bind, hence reducing the unbound free toxin and available to bind the myocardium. So it causes, it helps in this washout also, especially drugs such as bupivacaine, it helps in washing out, and it counteracts the deleterious effect of the local anesthetics on especially the fatty acid delivery to the mitochondria. This is at the level of the molecular level. So the injection, the amount that you're giving is an intravenous injection of about 1 to 1.5 ml per kg of intravenous emulsion for a minute, and followed by a bolus administration of 0.2 to 0.5 ml per kg. Then again, you have the adult dose and the children. Adult dose is about 12.5 ml per kg of 20% over 24 hours. And in the children, it is about 15 ml per kg over 24 hours. So this is the overall answer that is expected for the antidote of local anesthesia.
Great, ma'am. So, moving on to the next question. Can you please explain us about the extraoral mandibular injection techniques?
Yes, sir. So basically, again, for this particular extraoral, if you look through the literature, Melamid, I think the gold standard textbook that we all read, Monim's Melamid, always mention about just two extraoral mandibular injection techniques. But I would ask most of the postgraduates who are listening to this lecture to go back and read this book of Local Anesthesia by Roberts. It's a very old book, but if you're able to trace it, do read it. It does mention about 3 techniques which are mentioned about Kurt Thomas technique, and the second is Kantorowicz technique, and third is the Braun technique. The last 2 techniques are seen in few literature, but Kurt Thomas is seen in this textbook on by Roberts. So whenever we are talking about the Kurt Thomas extraoral technique, now this is in cases where patient is again bound with trismus, associated with any reason of infection or probably even TMJ ankylosis, and you need to anesthetize a particular area. So what you do, you need to have certain surface markings. The surface markings are related to point A, which is the anterior border of the masseter, which is point B, which is again, which is the midpoint of the tragal area of the ear. And point C is a midpoint of these 2 points A and B. And a point D, which is marked parallel line, which is drawn exactly on the posterior border of mandible, as you can see in this photograph. Now the 21 gauge needle with its length is inserted into the medial part of the mandible. So this is what Kurt Thomas technique proposes. See, most of these techniques, I think, as we wave out, they have been less used, probably due to technique sensitivity, and most of the times it is entering into the medial side of the mandible. So we do not have much access to this area, although it has been mentioned in literature, but very few textbooks are mentioning these techniques. The proposed technique of Kantorowicz also is very similar, where it mentions that a 25 gauge needle, which is exactly 1 to 1.5 centimeters towards the angle of the mandible, and to stay away from the facial vessels. And the needle is inserted about 4.5 centimeter along the medial side to the mandibular ramus, which is parallel to the posterior border of the mandible. Aspiration is performed, again anesthesia. It looks very similar to that, but only thing is that the surface markings are not very distinct in this technique. Next, coming to the bronze technique, here the target area is the foramen ovale. So the third division of the trigeminal nerve is our target area that needs to be reached. So what they do is that the surface marking of the zygomatic arch is done, and the needle is basically the drawings are suggestive of the midpoint of the region of the zygomatic arch is taken. And the depth is reached, it's partially withdrawn, and then the angle of about 30 degrees is maintained, and the needle tip is directed towards the foramen ovale. So the way it appears, each one's anatomical landmarks may be very different. The insertion of the needle also is quite technique sensitive. Again, the needle tip needs to be rotated at a 90-degree angulation. And if both the aspirations are negative, then only anesthesia delivery is done. So these are the three techniques. Apart from this, these two techniques that is mentioned in both the textbooks, Monims as well as Melamed, that is about approaching for the mandibular nerve through the zygomatic arch, that is the midpoint, directly towards the coronoid process of ramus and lateral pterygoid plate at the depth of 4.5 centimeters. This is also called as the extraoral mandibular nerve block. And another one is the extraoral mental nerve block, which you again go at about less than 90 degrees from the external surface of the chin area, that is towards the direction of the mental foramen, in between the premolar region from the extraoral region. So these are the various extraoral mandibular nerve blocks. Again, they are catering to the branches of the mandibular nerve for anesthesia.
Extremely informative slides, ma'am. I think
you,
many of us would have not even seen these pictures and information you have shared. Thank you very much.
Thank you.
Moving on to the next question. Can you please tell us about the contraindications of local anesthesia?
Okay. So this is one of the favorite questions of most of the examiners, and most of the times I think either the student tends to hurry up before understanding what is the contraindication we're asking. So there are two aspects. When we talk about exodontia, extraction is one part and contraindication of local anesthesia is another part. When we're talking about contraindications, we generally deal with contraindications into two broad headings. One is absolute contraindication. Second is a relative contraindication. Now, what do I mean by absolute contraindication is in a case where you cannot give local anesthesia. And so the absolute contraindication for local anesthesia is different from an absolute contraindication for extraction. Similarly, a relative contraindication for local anesthesia is where there is an existing clinical condition which stops us from giving local anesthesia, but in a few days or few months' time, the patient can be made fit or could go in for local anesthesia. So when I talk about this question, the answer is there are only two things. One is an absolute, which is a patient who is having a case report or he is having a case history of anesthetic allergy, or he is a known case of bisulfite allergy. Now, in this case, you cannot administer local anesthesia in these patients. A patient who is having anything to deal with the powerhouse of metabolism, that is the liver. If there is any problem, significant liver clinical conditions, any significant renal problems, any cardiovascular dysfunction, especially patients with any myocardial infarction or any history of any cardiovascular dysfunction in the recent past few months cannot be taken up, then of course you need to get the fitness, get the status of the system right, depending on the clinical condition that they're suffering. Second thing is that patient is having an atypical plasma cholinesterase. Again, this is required for the digestion of the group of local anesthetic chemical group of local anesthetic drugs, the ester forms, as well as that is why we are telling that when a patient is having any liver ailment, most of the time the amides are getting metabolized in the liver, and that is how if any person who's having ASA3 kind of a picture where he's not fit, then patient cannot receive local anesthesia because it can increase the toxicity of the anesthesia in the blood. Again, patient with the history of idiopathic or congenital methemoglobinemia can also be a relative contraindication, and patient presenting with clinical hyperthyroidism is again So each of this, if a patient is having clinical hyperthyroidism, we can waive out anything between having a vasoconstrictor or not, but yet if the patient is not fit, will not be taken for local anesthesia.
Kadir,
So
you are
you're muted.
muted, Kadir. Kadir, you
Oh,
are
sorry.
muted.
We have a question regarding the answer we discussed. Patient allergic to methylparaben, which drug can be used as an alternative?
I think most of the times they do say capryl hydroxycuprammonium toxin is the other alternative that can be used. This is what we've been taught, but I have not really seen this drug being used.
And there is one more question, ma'am. Why Ehlers-Danlos syndrome? So contraindication to LA. Not heard about it.
Ehlers-Danlos. So again, it has got autoimmune factors. So maybe an autoimmune condition again could be a problem, because Ehlers-Danlos syndrome is related to calcium as well as muscular problems in these patients. So it could be related to I think the toxicity of local anesthesia can increase in these patients.
Okay. Thank you, ma'am. So the next question is a favorite question from our students. How to improve the depth of anesthesia? How to make it better? So please speak to us about the buffered local anesthesia.
Yeah, so I think, buffered local anesthesia, as asked by most of the postgraduates. So most of these questions have been catered to. So buffered local anesthesia, as the name suggests, is nothing but you are buffering the alkalization of lidocaine. Basically, alkalization of lidocaine is done with sodium bicarbonate just prior to the injection. Why is this done? This is known to cause less pain than unbuffered lidocaine, especially in patients who are having a history of infection. So how is this buffering done? Basically, sodium bicarbonate, as we know it as chemically as NaHCO3, 8.4% in a 10:1 or a 9:1 ratio, that is 10 or 9 parts of lidocaine, that is epinephrine, which is 1% containing 5 microgram per ml, to 1 part of sodium bicarbonate containing 8.4 gram per liter. So it more or less closely resembles the neutral pH. Now we know that in any infection condition, the acidic environment is created, and that is how the efficacy of local anesthesia is curtailed. And probably this buffered local anesthesia is the solution. I think umpteen number of studies have been done trying to prove the efficacy of buffered local anesthesia in literature. Sir.
Perfect. Thank you so much for your kind patience in answering all our questions, ma'am. Thank you so much.
Thank you, sir. Thank you so much. I thank all the organizers also. I think we'll forward with the general anesthesia, and then I'll thank everyone.
With this, we come to the end of the local anesthesia session. On behalf of Tamil Nadu AVOMSI, we would like to extend our heartfelt gratitude to the mentor, Dr. Lakshmi Shetty, and moderator, Dr. Kathiravan, for their valuable contribution and sharing the knowledge. Thank you.
Thank you, ma'am. I thank Sasikala madam. I thank Dr. Elevenil, Dr. Jimson sir, Dr. Kathiravan sir, Dr. Balaji sir, who's also my co-mentor in this, Dr. Pradeep sir, Dr. Arun Kumar sir, Dr. Subramaniam sir. Thanks for the opportunity. And I thank AMSI, both Tamil Nadu as well as the central branch, Dr. Girish Rao sir. Thank you so much.
Thank you, ma'am.
Thank you, Sasikala ma'am. Thank you, Jimson sir. Thank you, Leonel ma'am. Thank you, all the sincere dignitaries. Thank you for the opportunity.
Thank you, Dr. Kathiravan. The moderator for the next topic, general anesthesia and sedation, is Dr. Pradeep Devadoss. Dr. Pradeep Devadoss graduated from Bangalore University and completed MDS from Meenakshi Ammal Dental College. He has been working in the Department of Oral Maxillofacial Surgery, Meenakshi Ammal Dental College, since 2007. He has been involved in undergraduate and postgraduate teaching for past 16 years. He has around 21 publications and many guest lectures to his credit. His field of interest include oral implantology, orthodontic surgery, maxillofacial trauma and distraction, osteogenesis. May I now request Dr. Pradeep Devadoss to introduce the mentor and start the program.
Thank you for your kind words, Dr. Sasikala. A warm welcome to all the participants. Introduce the mentor for the day. Today is Dr. Balaji in 1991 and MBA in 96 and MDS in 1999. Sir has worked as in different positions in various government dental colleges like in Thuthukudi, Viluppuram, and Sri Perumbudur. Sir has been awarded a fellowship in implantology from Mahir University, and he has a lot of journals to his publications to his credit. And we all know Sir for his caricature drawing. Sir is currently a professor in Tamil Nadu Government Dental College, Chennai. It's my pleasure to welcome you, sir. Over to you, Balaji, sir.
Thank you for the introduction. And I mean, I thank all the organizers of the event, especially Dr. Arun, Dr. Subramaniam, and the Secretary of AOMSA, Dr. Girish, who was our senior in the college, Government Dental College, NBC. And it's a day one of the session, and I am proud to share the space with Dr. Shetty. And I think let us go with the questions. This is, I think this is on conscious sedation and general anesthesia.
Yeah, the topic.
And thank you for allowing me to speak on general anesthesia. Though I'm not an anesthetist, I will try to do my best. I should do my justice. So let us go to the first question.
So just give me a moment, sir, that I'm just sharing the screen.
Yeah, sure. I have actually spiced up this presentation with some of my illustrations and some mnemonics so that the students can take away some points, can remember them. Well, as this is a examination point of view discussion, and there are certain illustrations which goes along with the understanding of the conscious sedation, and also the points should be discussed.
Sir, are you able to see the screen, sir?
Yeah, I'm able to see the screen.
1 second.
Yeah.
Yeah. Without further delay, we will go for the first question of the day. Over to sir. Sir, how would you assess the airway in pediatric patients?
See, the airway in pediatric patients differs a lot from that of the adult. As you know, the child, the head is proportionately large, especially the occiput part of the head, it's little bigger. And the infants usually breathe nose breathers, and they got the large tongue, then comparatively to the adult size of the oral cavity. And then the cricoid cartilage is the narrowest part, which should be always remembered. So these 3 points are very important. If you go from the point of examination point of view, these 3 things are really essential to proceed with the intubation. And also the epiglottis, as you see in this picture, the epiglottis of the infant, it is pointed to the actually it is large U shape, and it is pointed to the cephalad mostly. So this is a very important thing. And as you see in this picture, when the children is being laid down for the intubation, you can see the position of the tongue. It falls back. It falls back because of this tongue position, and also the occiput. So always, that a roll of cloth needs to be supported at the neck, which is essential for the intubation. So these 4 or 5 points are important: epiglottis, occiput, then the cricoid is the funnel shape. And I'm repeating this because it has to be taken home, and the tongue. All these four things are really very important from the point of view of how you. This is yet another picture which shows the cricoid ring, which is shaped like a funnel in a children. So this is the most important point from the point of view of examination and the VIVA. So you can see the tongue also comparatively, it occupies a large part of the space. Now then, how do you assess the airway after this? This the COPU. This is the index for assessing the airway for the child. So C stands for the chin. So you got 4 scores in that. So the normal score is very less, actually speaking. As it gets more and more, it gets. I mean, it is difficult to manage. So extremely hypoplastic is the number 4 for the chin, and then O is for the opening of the mouth. So it is if it is more, I mean, for 40 millimeters, as you know, it is you can see you can visualize. Anesthetist can visualize more, and then P is for the previous intubation. So the attempts were easy, or that 4 is for extremely difficult one. And then U is for the uvula. And next, I think you can go for the uvula, where you can see the soft palate is not visible, it gets the maximum score. And then the R is the range of the movement of the, motion of the child, looking up and down, so that the intubation and the angulation of the airway can be done by the anesthetist. So the predictable points you can see there. 10 predict is more than 10 is a difficult airway management. So this is an important point. COPUR is the thing which all of you should have in mind for a pediatric assessment. And then all these 4 points which I told you earlier: epiglottis, occiput, and then the narrow airway of the cricoid. So this is the Friedman pediatric assessment form, which is about the sleep history, daytime indicator, just for the sake of completion. Yeah, next. So now all of you would be should know about the Mallampati classification. I'm not going to go into the detail, but this is also an indicator for the assessing of the pediatric airway, especially for the children where the tonsillar grade should be incorporated into that pediatric in the modified Mallampati classification. Yeah. Yeah, I know the controversies in conscious sedation. Yeah, I think so.
Yes.
So first we need to understand what is sedation, what is conscious sedation, to go into the controversies of the conscious sedation. So first, the sedation. This is a definition for the sedation, according to the American Society of Anesthesiologists. So the sedation is an induced altered state of consciousness. It is an induced altered state of consciousness following the administration of a sedative agent. It can be anything. So there are 4 types of, 4 or 5, whichever agent, there are about 8 agents are there. And then 4 routes are there for the administration. So sedation is a induced altered state of consciousness following the administration of a sedative agent, which depends upon the interest of the, it can be used as a cocktail or a combination. With minimal sedation, so there are 3 types of sedation. Minimal sedation, you have to understand moderate sedation is the one which is called as the conscious sedation. So what is minimal sedation then? Minimal sedations are for the patients who are in a state of anxiolysis. There is an anxiety part is cut off and may have impaired cognitive function, but retain protective airway. So all the airway reflexes are in the control. And the ability to respond normally to verbal commands. You can easily respond to the verbal commands. So moderate sedation is the one which is called as conscious sedation. It refers to a state of depressed consciousness with a purposeful response to verbal commands. You have to differentiate between this and the minimal. There it is an impaired cognitive function, but retains protective airway and the ability to respond normally to verbal commands. Here it is purposeful response to the verbal commands. And light tactile stimulation, such as like double R tap, so is able to respond to the light tactile system. So we are actually worried about the. Yeah, you can go back to the previous one, the last one I wanted to. Yeah, in cases where the level of sedation becomes deeper than initially intended, we do not want that stage actually. So deep sedation is not wanted actually. So we are going to lose the control of the airway. So always it should be maintained in the moderate sedation. We do not want to go in a state of deep sedation. So this is where all the controversies arise. So always the sedation shouldn't be taken lightly in the dental chair. So the age limit is there. 16 and below, IV sedation should not be given. And for younger patients, oral and inhalation sedation are recommended. And always it has to be done under constant supervision of an anesthetist. At any point of time, it's not recommended that you can do it because of various factors nowadays. Without an anesthetist, it is my view that it has to be carefully monitored. So it has to be monitored before doing anything, because shared airway between the dentist and the anesthesiologist, because we are working in that space where we need to take the airway under control. So always you have to remember there are coexisting medical conditions like cardiac anomalies are also there, and the patient may go for arrhythmias also due to trigeminal nerve stimulation, which is a very thing in our oral environment. So the takeaway thing is there are three types: mild sedation, moderate, and deep sedation. The moderate sedation is called as conscious sedation. So this is once again I'm just putting the slide again. Continually maintain a patent airway. This is most important. So if you lose the patency of the airway, then it goes into the state where you have to go for an emergency. Yeah, this is the moderate sedation what we're talking about. This is the illustrations which I have done for one book which got published. So you can see what are the phases of conscious sedation. So induction phase is there, injection phase, maintenance phase, and then withdrawal phase. So how do you induce this by 100% of oxygen, 3 to 5 liters per minute for 3 minutes? Yeah, you can go back. I'll just complete it. Then in the injection phase, you got that is rapid and slow, where you stage by stage you induce the nitrous oxide. And then maintenance phase is for about 3 to 4 liters of oxygen for 1 to 2 liters nitrous oxide, and 3 to 4 in that ratio, 25 to 75 or 40 to 60. And then the withdrawal phase, which has to be done in about 3 to 11 minutes. So these are all the 4 stages of conscious sedation. Yeah, thank you. Next. So this is a pictorial representation of a conscious sedation, actually. As I told you in the first, the definition, pharmacology induced patient. He is in a state of depressed consciousness and is able to maintain the airway. That is most important. This is the stage where you should let go the patient, and then he is able to respond to voice. Whether he is able to respond to you, and then he is able to respond to a physical stimulation, not exactly a painful. Slight tap, gentle tap, he has to respond. Yes, Dr. So what are the drugs? So for the sake of completion, what are the drugs which are used for conscious sedation? This is a mnemonic which I have done. Proper meditation kit. This is called as. He's gone in a state of meditation. So what are all the drugs which are used in that? So proper, you can just take it for the drug which is called as propofol. And then in that down below is Dexmed etomidate. This is the drug which is in there, and then Medazolam. These are all the key drugs which are used. And then KIT, you can remember it's for ketamine. So if you put these drugs, and the other drug is fentanyl and Medazolam, mainly Methylphenidate. This will give you a clue for how to. You can remember this proper meditation kit where you can put all these 3-4 drugs into your mind, and then the rest drugs which can fall into place. If you remember these four drugs in this point of this mnemonic type, you can remember mostly all the drugs. Next. So these are the controversies. Still, we are in that subject only. These are all the various factors by which the sedation level is being assessed. Next, 0 to 5 scale. And then responsiveness, spontaneous ventilation as airway. These are the differences between minimal, moderate, as I said, and the deep sedation. So there is a very minor, a thread of difference between a deep sedation and general anesthesia. So it should be very careful not to leave the patient into deep sedation. It should be always in the line of moderate sedation. Thank you.
That was a very pictorial representation and good explanation, sir. I think most of them would have like sir said, the depth of the anesthesia is the most important thing what you have to maintain in conscious sedation. You shouldn't leave that phase, and the drugs what you use. Again, the duration. Always limit your duration to 90 minutes or within 2 hours. Yeah. We should not extending too much also. We'll go on to the next question, sir. What is the 2-4-6 rule in anesthesia?
The 2-4-6 rule is generally about the NPO, which we talked about before the surgery. Accepted by the AAGBI, it stands for the Great Britain and Ireland Association of Anesthesia. So previously there was 8 in that, actually speaking. 8 is for the normal meal. So now it's been taken out. 2-4-6 is 6 hours before is that. And we commonly say NPO because our patients, if you can categorize them, we won't able to take control of the patient and they won't really understand. So 6 hours NPO, we just say normally. But 6 hours prior to surgery, what are all the foods to be avoided? Like non-human milk, formula milk, clear, non-clear juices, gum, hardy, candy. Then 4 hours before prior to surgery, the breast milk will be applicable. And then 2 hours is only for clear liquids, water, apple juice, pulp-free. So now we normally do not, explain to the patient like this because it's really very critical for us if they misunderstand it. So we don't go into the detail when the point of view of exam of telling the patient. So this is what is generally been given 2-4-6 rule. Anything to add on?
Thank you for the explanation, sir.
What do you say to the patients? Generally,
yes, sir. Yes, sir. Whatever you said is very right. Yeah. We don't generally tell our patients too many instructions. We generally stick to 6 hours NPO and clear fluids for the last 2 hours. That keeps it safe. Otherwise, they get confused between clear fluids and juices, and most of the time they end up drinking something.
And they get induced by self anesthesia also. If it's a clear.
Very true, sir. Let's go to the next question. The next question is on retrograde intubation.
Yeah. See, the retrograde intubation, actually, it involves, first we'll go to the technique. Then all other things get failed, then fiber optic is also not there. And this technique involves passing a guide wire through a needle inserted into the larynx. And they're delivering the wire through the mouth or the nose. So we got a picture next coming up. So the topical anesthesia is applied on the oropharynx, and the injection is also given on the CTM membrane. And then you just put a syringe into that space, and then in that space of the crack, you insert the guide wire into that. It is pulled out through the forceps, through the oral cavity, or through the nasal. And then in the next picture, and then you retrograde. You insert the tube, endotracheal tube from the outside to the wire. So it is called railroad. You create a path, a track through which this tube is pulled inside through that space. And once it touches that area, the entry point of the pharynx, that you just pull out the guide wire. So it automatically goes inside the trachea. Now this is called as the retrograde intubation.
Yeah, for the benefit of the postgraduates, the retrograde intubation is one important VIVA question and a short note question. Most of the times we see it in the question papers. I think the postgraduate should be able to answer this both in questions and in VIVA. We'll move on to the next question. We'll move on to the next question. How do you choose an ET tube for various surgical procedures, sir?
So first, the ET tube, based on the age, it has to be chosen. Premature baby, the size is 2 to 2.5. Then full-term baby is up to 2 weeks, 3 to 3.5 that size. Then from 2 weeks to 24 weeks, 4 to 4.5. That is 2 year. That months. Then from 6 months to 12 months, the size is 4.5 to 5. Then an increase in size of average about 0.5 is given for 6 months size of age till approximately 6 years. And then you go to the used is approximately 8. And so these are all the size based on the age you choose it. Then you got the types like based on the surgery, you insert through the nose, nasoendotracheal intubation, and then the oral intubation. Then the most important thing is the submental intubation, which is most important for our specialty. When there is a pan-facial fracture and we need to check an occlusion, when there is fracture in the nose, basal bone fracture. And even now they have been started using this in orthognathic surgery, where you need to check the nasal cinching and the base of the nose, ala columna position. So it has been even in this aesthetic thing, we used to inform the patient regularly. Some I expect surgeons are doing this for orthognathic surgery now, so that the overall face is we need to if it easily evaluated with that having an endotracheal tube into the nose, we cannot really come out of the theater really satisfied sometimes. So this submental intubation is a real thing to be followed up. So this is how then submental intubation. The picture is there. I'm not going to go into detail. This is just a view for the exams. So then you got the fibro-optic intubation. This is the best thing where you can visualize these epiglottis trachea and the open parts anesthetist, and then you can insert it without the blind. Previously, the one thing, blind intubation was also there. If there is no this fibro-optic thing was not there before. So there were experienced anesthetists who used to do the blind intubation. And then, as I said, the retrograde intubation. So the fibro-optic is really a boom in our specialty. Yeah, next.
To the benefit of the postgraduates, the other thing what you have to know is the type of the endotracheal tubes. You have these regular tubes, then you have the ray tubes, then you have flexometallic tubes. Do you want to add any light on that, sir?
Yeah, the flexometallic tube is really beneficial, so that it is easily bendable. There's no kinking in that, and especially for long procedures in our maxillofacial aesthetic surgery, it is used more often.
Yes, sir. Thank you, sir. We'll move on to the next question. What is the 3-3-2 rule in anesthesia?
Yeah, 3-3 rule anesthesia is that there are. I did a small picture of the 3. Yeah, actually the pistol contains 6 bullets. So 3 and 3, and then 2 is that one. It is used to assess the. It goes into the neck. So 2 fingers. Yeah, you can go to the next one. This you got to target the Adam. That is the bulge, the trachea. The Adam's apple is there. So the first thing we'll go into the 3. 3 fingers should be inserted into the oral cavity. This is a rule to predict the difficulty of the intubation in the patient. So the first 3 stands for the finger, 3 fingers. Either it should be yours or the surgeons or the anesthetist. And then for assessing the opening of the oral cavity, so that to visualize it can be easily visualized the entry point. Then the tip of the mandible, the other 3 is to go below, the submandibular region. It helps to, estimate the tongue and the length. You can see the B picture here, 1, 2, 3. So it gives an estimation of the submandibular region, the length. So the narrower it's more difficult. Then the 2 fingers should be fit between the base of the mandible and the thyroid notch on the anterior portion of the neck. This is the aim for the Adam. So the larynx position, if it is too high in the neck, means there is only 1 finger goes. There's only 1 finger bed. It is really challenging. It's that. So at least should be 2 finger bed. This is the 3-3-2 rule for assessing the Adam. Yes, doctor.
That is again an important Viva question.
3,
The
3.
postgraduate
Yeah,
should
2.
know.
Yeah,
Thank you,
3,
sir.
3, 2, and 2, 4, 6. Yeah, thank you.
Going to the next question, sir, your inputs on total intravenous anesthesia.
See, this is an interesting subject, actually speaking. Total intravenous anesthesia, where this is a technique where anesthesia is done by intravenous agents only. So you don't have no gas aiding in that anesthesia. So given by IV boluses in drips. So this is TIVA. It's called total intravenous anesthesia. You have to remember that it's TIVA. That is what is given. Anesthesia is non-operative locations where inhalation anesthetics are difficult in those regions. So almost in all surgical procedures, IV procedures, in all these places in remote locations, then hypothermia, all these susceptible patients can, you have to use this. Next. So what are the advantages of this? You can see, no sudden concentration of gas or vapor, no mask over the face, reduced stress response. All these things avoids distension air-filled spaces in the body, less chances of emergency pneumonia because the gases into the spaces are not there. And there should be no smell of the volatile agents at all in the room. So all these things are an advantage of these technique, and the disadvantage, what they say, is pain on injection. As you know, is if there is an induction by an inhalation, that part of pain when doing an IV is nullified if there's a combination of the drug. And then shallow respirations, risk of bacterial contamination, as always there in all these things, and possibility of not finding the way if you only depend on these IV. So these are all, next. These are all the drugs which are going into this TIVA: propofol, ketamine, dexmedetomidine. So this is commonly called as dexmed in short. So we'll go to the next picture, which is really important in way of remembering this. These are all the TIVA complete anesthesia circle, like hypnosis, sympatholysis, amnesia. So all these things are done, achieved with this total intravenous anesthesia. So what are all the drugs? Yeah. Next. Yeah, this is very important picture, which you need to understand of how this TIVA is being. You imagine a kingdom, like there is the total control of this is a king, that is anesthetist, who is in the theater. He is the king, he is the boss. Even we surgeons only depend on him for our for our comfort and the outcome of the surgery. So he has got the control of propofol, which is actually a prince. So without that drug, the king actually doesn't go for a war. So here the king will decide that military in battle of anesthesia, whom to send in combination. You have to understand this picture so that you can easily understand and write, or you can answer. So the prince is essential for all the war. So if the prince is absent, he takes the first supreme commander or the second supreme commander. You understand? Not or both in combination will go, or even one can go with the prince. So he goes to every battle. Prince with one or two supreme commander are the best military of the king. So the prince can take one or two, like Dex or Heat with him. So always king will depend on prince. So these three things are very, very important. In absence of the prince and the two supreme commanders can also go, like Dex, ketamine can go without the prince. So you're all able to understand. Please see this picture once more. It's available in the net. I searched along with one of the PGs and I took it. And it is really important to understand, to keep this in mind. So the king of the theater is anesthetist. He's got a prince in the right, this propofol. Propofol cannot, without the prince, it doesn't go for a war. He takes ketamine and Dex. Along, prince can take ketamine or Dex, or even both. Or without the prince, ketamine and Dex can go. And below down in the blue is the commander, fentanyl and remifentanil. So he is a commander. He can go along with the supreme commander or the second supreme commander. So all others are soldiers. So you got midazolam, you got dexamethasone, you got lidocaine, which is a magic soldier. All these things you have to read the properties, but this is the answer for the kingdom. If you can read this or keep in mind properly, you can answer or understand this total intravenous anesthesia. So next you will understand even better, like how it works. The next picture. So this is what I was telling. Different combination. You can see the prince, which is propofol. P for prince. So he is there. I mean, almost everywhere. See ketofol. So ketamine is the first commander. So is the ketofol is the ketamine plus propofol plus dexmet. This is an even bigger war, where the prince has taken both the commanders. Then ketodex, ketamine plus dex. Here the prince is not there. It's maybe it's a small war. And then you got the fentanyl and propofol or remifentanil with propofol. There only the commander, not the supreme commander, but the commander is going. If you can go back to that slide, the before one. See, the commander is there. Fentanyl and remifentanil is going along with the prince. That is propofol. Yeah, can go back. So this is how the TIVA works. So the last one is PDF, MDF, and ketomet. This is how they go for a combined work. This is just to understand and easily for you to relate. I'm not going to go into this details. This is just for the sake of completion. The various steps.
That was a wonderful representation,
yeah,
sir. When I saw that, I was really amazed. I thought you made it.
No, I didn't make it. The first one was mine. I mean, all those things. This I really got it in the net. I got myself immersed into this. This is the first time I am also reading so elaborately.
Yeah, it explains everything in a very simple way to remember for the exams.
Yeah, that's why I was.
Very nice.
Yeah, thank you.
Coming to the last question, sir. The contraindications for conscious sedation.
Yeah, obviously, the contraindications are incapacity of communication, and you got the breathing, mouth breathing. Chronic COPD is the neuromuscular disorders, patients under chemotherapy, serious psychiatric and behavioral disorders, and respiratory airway obstruction. So these generally all things which are incapacitating to the airway, and then obviously psychiatric disturbances, and then drug combinations. Patients who are using a contraindicated like thiazam and flunitrazan, Ritnovir, the protease inhibitors, then acute glaucoma drugs. So these are all drug interactions which you have to be careful. And of course, pregnancy.
With this, we come to the end of the questions.
Thank you, really, Dr. Arun, Dr. Subramanian, and all the team, 11L, Dr. Sashikala, Dr. Pradeep for moderating it so well, and all the students who are patient enough to go through this sedation.
Thank you, sir.
Yeah.
Yes, Dr. Pradeep.
No, Dr. Sashikala, you can go on. I was talking about the few questions which are in the chat box.
So that we take it later on, sir. Next session, last session or later on, sir. Yes.
Okay.
Yes. Yes, sir. Thank you, sir.
With you can pass it on to anesthetist. Yeah.
Yes,
you can
sir.
pass it on to an anesthetist for the answers.
Yes, sir.
I think most of them we covered, I think, sir. Somebody has asked what are the types of ET tubes and things like that. We have covered it, sir.
Okay.
Yeah. Thank you, sir. With this, we come to the end of the session. Yes, sir. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentor, Dr. Balaji, and moderator, Dr. Pradeep, for the significant and invaluable contribution and sharing their extensive knowledge. Thank you, sir. Thank you.
Thank you so much. Thank you. Thank you so much. Thank you.
Yes.
Yeah. Thank you, Balaji, sir. Thank you, Pradeep.
Yeah,
for
thank
an
you.
excellent,
Thank you.
Thank you, Dr. Arun.
for the elaborate
Thanks for the
preparation. See, PG is just watching. See the amount of preparation the examiners have done for you guys. Right. This is how you have to prepare for the examination. So by actually we are also learning a lot from these things. So that is the best thing about these sessions. Thank you both Lakshmi Shetty,
Thank you,
Kathiravan,
sir. Thank you.
and for your excellent preparation and then dedicated work. This is not easy. Sitting in an exam is like sitting in the student seat, right? So, and the dedication is clearly very evident, and the amount of preparation has gone into answering these questions. Thank you very much, both the moderators as well as mentors. And thank you, Sasikala, Ilavenil, Vandana, and Kalpa, and Arun Vignesh for coordinating this event in a seamless manner. Once again, thank you all for the participants, also for the support. Thank you, Jensen. Thank you, Subra sir, President, who never says no for any program. Thank you all for the patient listening.
Thank you, sir.
Thank you.
Yeah,
Thank you,
thanks.
Arun. Thank you, Arun.